Make sure there's no ninjas, okay? Airway, ABCs, okay? You guys did everything. You guys already know this. Suction, right? I like to lean them on their side when I give medications. I don't like to have a free floating needle or try to get an IV when it's seizures, right? Until they're totally calmed down. There might be a part where when they have the grand mal suit, there might be like a 30-second window where they kind of calm down before they start again. You time it then, or you can go intranasally with Versed. That's the safer way to go. That's only my preference, okay? I tend to have them sideline. I tend to put my leg down so they can't roll back at me, and I tend to go over them. That way I'm behind them instead of in front of them, in case they vomit or they come out swinging or they bite and clench down, okay? Remember, it's not the patient, they're not consciously doing anything, okay? We're gonna oxygenate, we're gonna make sure that there's an opiate induction, okay? We're gonna do all the things. You wanna rule out stuff more than rule in stuff, okay? Status epilepticus, management, you guys do that. All right, 2 types of stroke, ischemic and hemorrhagic, okay? Which one's good, which one's bad? They're both bad, okay? I like that, okay? So yeah, they're both bad. One's quicker than the other, okay? If you're old, we're thinking what? Subdural hematoma. If they're young, epidural hematoma, okay? Thunderclap headache, gotta know it. The patients will literally say, I've never had a headache like this. They'll present like this. Oh, fuck. Just help. They're gonna literally be like that. They're gonna be in so much pain, and they're not gonna be able to concentrate. Normally they'll have closed eyes. They won't be able to speak to you. They'll be clenched up. They can talk to you. You're good. It's when they no longer complain about that headache that like shit has gone bad. Now you're probably gonna have to intubate and it's gonna get ugly quick because they have so much pressure that their frontal cortex can't even register the pain to articulate how well this is gonna go. AMS. AO tips. You know TIA from a stroke? TIA is transient. Yeah. There we go. Less than 24 hours, you get resolutions. What do we treat it like?
A stroke.
Like a full stroke. Unless any of you got a cape with an S on it, we don't have x-ray vision. We're not doing the things. Okay? All right. Syncope. Ooh, loss of consciousness. This is different than just getting woozy. Okay? Syncope is a full loss of consciousness. Right? Go to a boxing match and you see somebody get knocked out, that's syncope. You know what I mean? When they go out. Anybody get up real quick and get woozy? And you ever get up and look at, look at your Netflix bill and you're like, oh, Jesus. Okay, like, that's woozy. That's not syncope. You didn't pass all the way out. Okay? All right. So you can have cardiovascular, meaning you got insufficiency. We're not getting the blood to the brain. Little old Mima, going to the bathroom. She bageled herself out. She used too much of her parasympathetic. Where would you find her in the house if she bageled herself out?
Toilet.
Between the tub and the toilet.
Always between the tub and the toilet. Always. Always. Okay? You're at the gym. Got a bunch of high school morons together. Which is awesome. Got a bunch of high school kids with no supervision in a weight room. What could go wrong? All of the things. Man, I got it. Simple, full out. Okay?
Good night.
Anybody here do a Brazilian jiu-jitsu? They do a jiu-jitsu. Hey, anyway, faca português, right? In Brazil, they talk with this. We're gonna do jiu-jitsu. Let me show you my friend. And they put you in a rear naked choke and you tap. And they go, oh, it's okay. He's gonna come awake. Okay? Full syncope, right? Because you got choked unconscious. Okay? All right. So then we can have non-cardiovascular. right? Because that's that's the cardiac, right? Metabolic, didn't get dialysis. That's a big one, right? Because your electrolyte balance and your perfusion's off. Idiopathic doesn't mean you're an idiot. It means we don't know the answer. That means idiopathic. When you have patients, never say idiopathic unless they're in the medical field, because they think you're insulting them. So we don't know this cause. A lot of people have this, and there's no certain reason why. Some of the research isn't clear yet. Don't say, hey man, you passed out, idiopathic syncope. What you call it? Like, you don't want to do that. We don't aggravate. So idiopathic means no known reason, but I never express that term to patients. Right? It's bad PR. It just looks bad. It sounds bad. Everyone's got a camera. You call me. Then they literally edit that part where you say pathic, and they mute that part. You have a seizure because it's idiot. Like, there you go. So we don't do that. Extended unconsciousness. Is that syncope? No, it's being unconscious for a really long time. Syncope means you go out and then you come back. Okay? What's really long unconsciousness with no breathing? Respiratory arrest. What's unconscious for a long time, no breathing, no heartbeat? Dead. You better start doing the pushy, puffy thing, okay? Like, we need, so if they don't come awake, you're checking for a cardiac arrest, okay? Don't sit there and like, well, they'll come awake. They were just talking to me. And no, Mima didn't just go to sleep eating Jell-O. She literally had a heart attack in front of her, okay? All right, management, same as always. BSI, scene safe, maintain the airway, support breathing. If they have a syncope and they're about to fall, use a stair chair. No. Bring them down slowly, make sure they don't have trauma on top of the syncope. Okay? IV access, we need to check. What are we checking? What pressure and sugar. Get a cardiac monitor, right? Because you can have what? A trigen beads, you can have ventricular arrhythmias. They don't get blood that second. Okay? We're also going to do what? What do people never use? I never took nothing. Drugs. How many times somebody passed out? This. You guys all know the junkie shuffle, right? I like bird that's just like hanging your head.
That's my Saturday night.
I didn't take nothing. It's a junkie shuffle, man, and they never fall over. You can bet how long it takes them to fall over. Always bet 2 minutes. Okay? Unless there's another one that can trip over. Okay, so you want to make sure that they didn't OD, they didn't take nothing. Okay? All right. Reassure the patient in transport. That's good. That's pretty good. Okay? I tend not to ask for health insurance information until we're at the hospital. I do that because I don't need them to worry about the bill after they've had an episode. Whether stroke, TA, trauma, like, no, we'll deal with the bill later. I got some people, along with the EKG, while they're setting up vital signs, they're like, Blue Cross Blue Shield, Demini, like, no, you're there for patient care, okay? You think I'm joking about
I
that?
know you're not. There are some people like this.
Yeah, like, all right. Like, I normally get the insurance information after they're at the hospital and totally stable. Okay? If it's a long transport and it doesn't compromise care, cool. Okay? But I tend to be like all in. I tend not to be like, oh, I'm half insurance and I'm half medic today. No, I tend to be all medic and then I do the insurance thing. Okay, that's just me. All right, seizure. Any position, warning, jerking motions, remains unconscious, they got the seizures. Syncope usually begins going to a standing position. Going to a standing position or being in a standing position for a long time. Do you guys know what a body catcher is? Do you know what a body catcher is? What's a body catcher?
In which field?
Army.
I don't know the Army, I know the Marine, and I know the wilderness stuff.
Probably the same. Army, Navy, during their ceremonies, they're so long and locked at attention that all this blood is here. If they bend their knees, that blood shoots all the way down through your tibial, posterior tibial artery, they pass out. So there's literally people walking to check. When people start getting wavy, they're called the body catchers. They catch your body before you hit the deck. This happens a lot. And so your trick is, if you ever have to pay attention for a very long time, unlock one leg, unlock the other leg slowly so nobody notices. This will help pump the blood so you don't pass out. If not, you're in an airplane and you know G-force, you see everybody pass out. You ever see it like on the videos? Why does everyone pass out? All that blood gets rushed out of the brain down to the body. What's your job in a plane to do if you're getting G-force? What do you guys gotta do? Squeeze your glutes, squeeze your blood, squeeze, so all that rusher is coming up. Didn't know that, huh? Squeeze your glutes. Gotta squeeze everything, all of it. You'll see like those senior citizens, 80 years old, they've been pilots forever. You see some 19-year-old kids. All right, headaches, vascular, migraine, cluster, tension, organic. Which one have you guys had? All the above, organic. Price of organic food, expensive. Okay, so we can get it vascular. You can have it where your arteries open up or close too much, right? Some people get migraine headaches on that one, get too much caffeine at once. Lack of caffeine is usually a big one, right? Okay, migraine headaches, they tend to be cluster, non-cluster, or non-oral, right? These are not to be confused with strokes, right? Because you have to do the rest of your exam. That's what you want to make sure. They got a headache, great. They got aura, great. Okay? No motor deficits, no speech deficits. They've had a history of this one. Okay, we're calling this migraine headache. Okay? Tension headache is going to have a band-like pattern. You're going to see bounding of the pulse. Sometimes the suboccipital artery. Sometimes when you drink the next day, you've got that pulsing headache. Sometimes it comes back there. Not saying you guys drink it all.
We just call that the paramedic headache.
Oh, okay. Very nice. Very nice.
Do you know what fixes it? More drinks.
More drinks.
You know,
hungover if you never get sober.
there you go. I like it. I like it. I call it the Vassar turf lobby headache. The dude is having a stroke. Lobby. Okay, like that. What does the patient do in the onset of pain? Anything provoke or relieve the pain? All right, if they have a headache after they just went skiing and fell down the hill every single time, what am I thinking? Headache or maybe a bleed because they're really bad skiers. Okay, so you want to make sure that you line it up. Okay, if you were doing nothing and you just got a headache, okay, that happens. All right, you get your Taxol. Okay, you got a headache. Okay, you're fighting your stress, you got a headache. Okay, but if you have trauma, history of it, now you want to look further in. What type of pain is it? Anytime someone loses vision, okay, we're not playing, we just wait it out game. Okay, you want to think of your ophthalmic artery, think through a small clot, and you got your trigeminal V1 nerve giving pain. Okay? Acute versus chronic, take anything to help it all. If pain resolves because they took an over-the-counter NSAID or something like that, I know it's not a ischemic clot because that wouldn't help the clot. Okay? All right. We allow stroke. That's it. All right. Scene safety, make sure there's no ninjas, maintain airway, do your neural, establish IV, blood glucose as always, monitor cardiac rhythm, look at their eyes to make sure it isn't an OD. Okay, we're making sure no pinpoint pupils. Okay, reassure the patient and transport. Great. Weak and dizzy, awesome. They want to be seen in the ER faster. How many people got a patient that said, oh, I'm weak and dizzy? They think they're going to be seen faster if they take an ambulance. So weak and dizzy is one of those that I hate because there's no specific. What's weak and dizzy for you might not be weak and dizzy for me. Okay? So you're going to take all your vitals, you're going to get your blood glucose, and you're going to do a full workup. Okay? Then when you make sure that everything is good, your cardiac monitor is good, because you don't want to have any problems, you'll BLS with them if they're okay. Let's be honest. You're going to have tons of this. And the one time you don't check glucose, it's going to be 32. The one time you don't do a cardiac monitor, it's going to be in VTAC or something crazy, because you didn't check it that time. Do all your tests, and then the deal. Okay, don't do the, wow, it's me again, it's the 5th time today, right? Because the 5th time is the time that she's gonna have a big one in the back and you're driving and she's like, she ain't doing so good. Yeah, she's not doing what? Anything. You know, mom, like, so just do that. Okay? Vaccine, make sure there's no ninjas. Okay, no one's coming out to stab you. IV access, counter rhythm, glucose, there you go. Antiemetic. Okay, so what are you guys gonna use? Antiemetic.
Zofran.
Zofran. That's pretty good. Zofran. Are we gonna give them oral glucose?
No.
They feel nauseous. I don't try to give oral glucose. Right? Like, why would you? I'm not gonna risk it. I don't. That stuff is bright, like red and orange. I don't like bright red and orange for my skin complexion. So, like, I'm not putting it on. So, if they got low blood sugar, I might actually just do a quick IV drip. Just nice, easy. Like I said, I don't want anything oral if they're feeling nauseous. Okay? We give them graham crackers? No. Feed them peanut? No. Not doing that. Just take them in. Neoplasms. Alright, neoplasms. Tumors of the brain.
Not that we're diagnosing those pre-hospital.
Yeah, you know, who here thought Henry Cavill was a good Superman? I thought it was good. Okay, the new Superman's gonna suck. But none of us have X-ray vision, so we are not able to diagnose neoplasms. Anyone here ever have brain cancer? I'm the only person here that had brain cancer. Okay. You usually get strokes or epileptic seizures when they get big enough. Okay? And so when that happens, you're gonna rule out stroke and you're gonna scan. And that's why it's good to get IV access with contrast, because they're gonna see the neoplasm. You're gonna treat it exactly like a stroke or seizures. You're gonna maintain airway, you're gonna make sure they're gonna show all the symptoms depending on where the lesion is or where the tumor is growing. Okay? At best, right, you have it just kind of an outgrowth that's on the bone, and they have what's called osteosarcoma. At worst, they're gonna have something like me, where you had to go in and take out parts of the brain. Okay? And so I have it. My wife knows. Anytime I get, like, EMS showed up one time because I was having AFib due to infection. Long story. But EMS showed up and they gave me a test, and when you see me smile, I actually have a lopsided smile, and I can't hear on this ear. My wife was like, "That is baseline. That's his baseline." So it's gonna present just like a stroke. Okay? Alright. History is always good. Don't get it just from the patients. Patients lie. How many times you take a patient's history and then when you get to the room, it's totally different? Totally. Like you know how many times I just like get a nice history and the patient will come in, the doctor will be like, "Hi, do you have anything wrong with you?" "Well, I got this." You love, like, I think it's a joke, but they always do, okay? So, if you ask them for allergies, ask them, say, "Hey, do you have any allergies? Anything you can't eat? Are you allergic to anything, these things?" "All right, great. Any medication you can't take?" And they're like, "Wow, I can't take this, but I'm not allergic, it just reacts badly with me. I'm told I can't take it." "Why are you told?" "I almost died last time I took it." Like, that's an allergy. Like, no, allergies are only food. Like, all right, here we go. Okay? So you want to make sure that. 22-year-old male, unconscious, own dorm room, by his roommate. Who's thinking the roommate work? Party last night? Oh yeah. Breathing, 10 minutes. Skin is hot and moist. Pulse is rapid. What were you thinking?
PCP.
Okay. I'm thinking you partied hard. Okay. But is he alive?
Is that
Okay. 10 respirations per minute. I would check oxygenation level, get a blood pressure, BGL, right? Make sure no opiates. Because people do dumb things at parties, right? And things are laced. Things are laced. So they might only say that, "Oh, I smoked this or I did this." Things get laced. So you never want to assume that everything is on the up and up. Guy loves to party, been acting a little off lately. Doesn't know any medical issues. standard roommate. I got friends, I don't even know their last name for like 20, 30 years. And you're like a guy, you're like, yeah, man, see him at the gym. Like, that's bench bro. I don't know his name. That's it. Egg on his forehead. PE seems normal. Egg on his forehead. What do you guys think? Okay, fall. Subdural hematoma, maybe epidural hematoma. But at that point in time, if he's unconscious, I'm thinking that, right? I'm getting collared, vitals, and I'm treating it, right? Because if he's not responsive, I'm gonna think worst case scenario, just so they're ready. Okay? Right. What could be wrong with the patient? He's hot and febrile, right? He could have other disorders, but what's the most pressing one you want to think of? Right? Subdural and epidural, right? Because everything else you have time, that's the most expedient. Does that make sense? What we're trying to do? Trying to rule that out. And you know what? Brain abscess. Okay. He's hot. Meningitis is another one you get hot. You can have viral infections that make you hot. You can have syphilis, chlamydia, right? So Simon's symptoms, lethargy, hemiparesis, nuchorigidity, right? Nuchorigidity means you can't bend forward, right? Headaches, nausea, vomiting, just everything that looks like a stroke. Everything looks like a stroke. It all looks like a stroke until you have a CT scan and labs. Everything looks like a stroke, so treat it like a stroke. Because that abscess, it could have popped, right? Sometimes they're encapsulated, or it can be growing and creating so much pressure in the brain that it's effectively causing ICP. It could be like almost like a ICP hyperpressure. Okay? Most common type of seizure in kids. Febrile. Super stressful. Anybody here have kids? Super stressful, right?
You know, I don't know why. I think I've seen somebody working in EMS that when my daughter did have one, I called the pediatrician. I was like, do I go to the hospital for this? And she's like, yes.
Yes, you do.
Yeah.
She like,
More likely it's a viral infection that got
Yeah,
really
she
bad.
did have a virus. She did have a virus.
Do you know when you have kids, there's no instruction manual?
I will say my daughter choked once, and anything I thought I knew about, like, kids choking went completely out the window in that moment.
My daughter almost choked to death in front of me.
Yeah.
She grabbed a little mandarin orange. She was just walking. She must have been like 10 months. And my wife came over and she peeled the mandarin orange and left it on like a small table. She grabbed it. I was playing video games at the time. 2 sheets to the wind. I was drunk. I was playing Destiny. I was saving the universe once again with no thanks. Okay? How many times I saved the universe on this shit? And so my wife comes over with Francesca, and Francesca is purple, and my wife is red with tears. She grabbed her. I'm wasted. A few black clothes, little stomach press, this mandarin orange with the peel comes off. And her back, go back to saving the world once again.
That's
Okay?
not how I reacted when my daughter choked.
I had a few more drinks. Woke up the next day and was like, hey man, I had this weird dream that Francesca was choking last night. And my wife was in tears and had to learn CPR the next week. She would go to my office and learn because we had a mannequin there. She's like, I kept it together. I kept it together. I go, oh yeah, you look like it. Okay, you know? But I'll tell you this much. For that 1 month, I did nothing wrong at home. Like, I could have left that toilet seat up. Like, I just...
With no toilet
Yeah,
paper.
I mean, it only lasted a month. So, this is going to be ready. And if you feel a hot baby, ice pack growing area, make sure you're ready to go. Okay? And you're going to be bagging, and you're going to make sure that everything is going well. Okay? Be ready. Drug administered for seizures. Where we going? Where's it first? Here we go. Benzodiazepines, right? Valium, Versed, right? Ativan. Okay. Bradycardia, bradyapnea, increased blood pressure, widening pulse pressure. Ooh. Bradycardia, right? Increase. Hey, we got some ICP. Here we go. You got your phages, receptive, expressive, global. Global means they can't do both. They can't receive it and they can't give it. So they're looking at you. You ask them. Caw-caw! Like on top. Like they're doing all of it. They're doing all the things. okay? Versus receptive, like, sky is orange. All right, that wasn't the question you asked, but at least it was a comprehensive sentence that made sense, okay? All right. Cranial nerve disorders. Ooh. How many cranial nerves? And they go top down, right? So we got 1, olfactory, 2, right? Optic, 3, ocular motor. Because if you can't see, there's no reason to move your eyes, right? Great. Then we got what? Trochlear, right? SO4, superior oblique. Okay. Then we have your trigeminal, because there's 3 branches of the geminal. Gemini meaning twins. That's essentially why it's called trigemini. V1, V2, V3. Okay. Then we got cranial nerve 6, abducens. That makes your eyes go out. So if you have abducens paralysis, you're cross-eyed. Okay. Then we got what? That was 6. That was lateral rectus. Or 6. Then we have 7. 7 is what? Facial nerve. Smile, facial expressions. Nothing with mastication. It's only motor only. And special sensory touch. Taste to the tongue. Anterior 2/3. And then you have your what? Vestibular cochlear. So with balance and hearing, that's going to be cranial nerve 8. 9. Glossopharyngeal. Taste the back third and your swallowing reflex. Okay. 10. Go gamble in Vegas. Rest and digest and eat at the buffet. That's it. 11. We pick things up and we what? We put them down. So that's your trap and SEM. And then what do you got for 12? Hypoglossal. So all of you know that. No problem.
And if you don't, you have to study it.
If you don't, I think Josh Brown did this lecture.
He may have.
And he asked me, does anyone in the class know cranial nerves? And I was like, yeah, I know them a little bit. He's like, oh, sure you do. He's like, tell me about each single one. I'm like, all right, here we go. And he made me sit up in front of the class and tell the whole thing. Okay. All right. All of these are essentially going to look like what? Stroke. So you're going to all treat them like what? That's it, right? You're going to have an acoustic neuroma, means they're going to have ringing in the ear, hearing problems, right? Glossopharyngeal neuralgia, they're going to have irritation, they can't swallow, they're going to call hoarseness of voice, okay? Trigeminal, they're going to have pain in the distribution of the trigeminal nerve. V1, V2, V3, okay? If they have Bell's palsy, facial nerve, so they're going to be able to bite, they're going to be able to chew. Because trigeminal only does mastication with V3. You're going to see it. If one side of the face is going to be like this. Is their blood pressure going to go up? No. It's a virus in the facial ganglion with the semilunar ganglion inbreak. Are you going to treat it like what?
Stroke.
Stroke. Treat it like stroke. Let them rule it out at the ER. Okay? Great. Meniere's disease. Ooh. Meniere's disease can be post-viral infection, can be, believe it or not, they have some Meniere's due to bad water, right? It's unilateral. What are we going to consider it? Stroke. Okay? All right. Dystonia. Abnormal muscle spasms. All right. Who here's ever worked out? And for not working out for a while. You ever get the twitches afterwards? Get a little bit of fasciculation. That is not this. That is like, my chapter, legs cramp, right? This is more like, hey man, that's what it looks like. That's what it's gonna be, okay? Be either postural or be extreme. What are you gonna treat it?
Stroke.
Stroke, okay? Until otherwise. Yeah, we can do Benadryl, but the reality is if they're having chronic movements in there and they call you and it's uncontrolled, you can treat with Benadryl, but what am I still going to get tested? Right? It may be a small neoplasm in the frontal cortex that controls motion. Do I have x-ray vision? So where are we going to go? We're going to go we're going to treat ABCs and we're going to control that, okay? And hopefully they rule it out, but I'm not going to sit there and just give them Benadryl and send them home. Okay? Got to make sure that we do the whole thing and what's right. You can have a problem with your neurotransmitter. Myasthenia gravis is one of them. Duchenne's disease is another one. Okay? But you can have the last part of that myelin tissue isn't making the axon electrical activity go straight down. It's going everywhere, so you get uncontrolled motion. So but I don't have a biopsy lab in the end, I can't do slices, so we're gonna go right into the ER. Okay, ooh, infectious disease. Meningitis, who gets it?
College.
College, that's good. How about Marist? They doing that over there?
Yeah.
They doing the things? How about Hudson Valley? Oh, sorry, not Hudson Valley. How about Dutchess? They doing the things? How about CIA? They're doing things. Everybody's doing things. Okay? So what is meningitis?
Bacterial infection of communication.
There you go. You can have viral or you can have bacterial. Okay? And so you get infection. Infection makes everything sensitive, and that's right in case it breaks. So, anyone here ever have sciatica from a disc problem? You can't touch your feet because you're stretching your nerves over that disc herniation. Well, same thing with your meninges. So, what patients can't do, they can't do this and call, because it increases the cerebrospinal pressure, and they can't lift their leg like that. That's Brzezinski's and Kernicke disease. Okay? But meningitis, when it gets real bad, it can spread. That's the meninges. Well, what's under the meninges? The brain. So we don't want infection to start spreading. So they need either an antiviral or they need an antibiotic. Usually it's a spinal antibiotic or or systemic antiviral. Okay? And so you're going to do the same thing. You're going to treat just like you would a stroke, secure everything. Don't call in a stroke. But you're going to treat them, securing the airway, breathing. You make sure if they're hot or they got a positive Brzezinski's or Kernicke's. That's another sign you want to make sure. Okay? Can't do that. Put them on the stretcher so you can do a straight leg raise. Okay? They'll jump back and try to kick down at you, even though they don't want to. Okay? The other ones bring the head up. They'll try to bring the feet up in a fetal position to compensate, or they'll buck backwards. Okay? Very, very important to know.
Kernicke sign is an indication of meningeal irritation. With the patient's in mind, flex the patient's hip and knee. Then extend the leg at the knee. Back pain and resistance to straightening is a positive Kernicke sign. When the sign is positive bilaterally, it is even more suggestive of meningeal irritation. Okay, Tom. Before you wake up, I just want you to tell me what you feel as I do this. Okay.
All right, that would not happen.
This is a positive Kernicke sign.
Okay, no. All right, that no. Kernicke time looks like this. Here. Try to show you. I'll show you what Kernicke time looks like, just so you understand. This is what it looks like. And you just try to bring my leg up. Ah! They're gonna go like that. They're gonna jerk away from you. They can't do it because their whole meninges is on fire. Okay. Same with Brzezinski's. When you put the head down, you just like this. They're gonna jump back. It'll be super painful. Okay. They're not gonna be gently like Tom was. Okay, in the video. Okay? I don't know. Look like that doctor had a grand mal seizure. I swear to God, he looked like he was sedated. Okay, it's not gonna happen like that. Okay, they're gonna jerk back. They're gonna be hot, and they're gonna super painful. Here's the kicker: it's not gonna give pain in a sharp radiation like sciatica. It's gonna be pain all the way up to the neck because all of the meninges are inflamed. Sciatica is pain just going down the leg. So you bring up the leg, and they're like, "Oh, I got pain down my leg." No, they're gonna have pain because all of the meninges are inflamed. That's a big differentiation between the two. Okay, shingles. Well, here's that chicken pox. Okay, what virus is it? Right, herpes.
I have shingles too.
Yeah, shingles. And it's in a small band. What happens, that virus sits in your dorsal root ganglion and it stays there, okay? And when it becomes active, when you're under stress, you're going chemo, or you're old, because being old sucks, okay? You're gonna get a patch of band that blisters in a dermatomal pattern. Is it fatal? No. Is
Wish
it
it was.
painful?
Curly hair.
Here's where it becomes a problem. Trigeminal nerve or facial nerve, it starts becoming a pattern, right? Because what? Facial motor for facial expression, so it's trigeminal. It sits in the trigeminal because it's sensory. You're going to get a band. It's going to be around the eye or around the nose or around the mouth. it's not so much as life-threatening, but it's painful and it starts changing people's way of life. Because if you're older, you're not eating well, and now you get that, you're eating even less. Okay? All right. Polio. Anyone here have polio ever?
Still use the iron one.
What?
I still use the iron
You
one.
still use it at home. Polio. Polio is what? Inflammation of the myelin, right? That myelin, and it's going what? Usually to the phrenic nerve. Everybody needs to realize C3, C4, C5 keeps you alive. Your phrenic nerve. So anytime you got a neck injury, right, and it's above C5, meaning the arch, right, I brace and I monitor their breathing. Because that breathing starts decreasing, ooh, we got trouble. Okay? All right. Fatigue, headache, they're gonna be hot. Okay? Here are the people that get polio. People that come from countries that don't have the polio vaccine readily available. Okay? How about the next one? People that don't do vaccines. Okay? So, normally, what I ask people is, hey, I have a question. Have you had the normal vaccine scheduled? Okay. I ask, you had a tetanus shot? You had your polio vaccine? I start asking that. I don't ask specific ones besides those two, because those are neurological. Whether they have the other diseases or whatnot, I'm going to treat exactly the same. But I need to know. And they'll tell you whether I've had all my vaccines or I don't believe in that. I don't believe in the medical industrial complex. Like whatever but they'll tell you. Just ask. Okay? Alzheimer's. Yeah. Alzheimer's.
Like that every day.
What was it? Alzheimer's. Yeah, that's it. Neurodegenerative disorder. Cause dementia. Parkinson's. Low dopamine is your substantia nigra. Most famous case, Muhammad Ali. That was concussion induced. But what happens is your dopamine's there, and you have this pathway in your brain, right? I want to move this. My brain says, go to my arm and move this. And I just want to put it here. Nice, easy, fine motor. Okay? Because my body slows me down from doing that. Okay? Parkinson's, you don't have enough dopamine to slowly, right, coordinate. Sometimes you get attention. Tremors. As you start moving, it's a little bit easier. But your face doesn't have enough dopamine to regulate. And so, Parkinson's is one of those. But it's bilateral because it's everywhere. So you could rule it out from a stroke because you know you're going to do your ABCs, you're going to do your glucose. They're probably going to have a history of it, right? But they're going to have a blank effect, and it's going to be bilateral global. It's very that cogwheel rigidity. Versus stroke, it's going to clench you up like this, clenched. They're going to be this, but when they start moving, they might actually be better. Okay. Lou Gehrig's disease. Anybody know who had this? Lou Gehrig. That's a good answer. The dude in the wheelchair. Who's the dude in the wheelchair? I thought he was faking. I thought if you wanted to get people to really listen to you, fake it. Right? Just be like, breathe out of tube and just be like, the world's gonna end, we're out of chicken. Like just like say some crazy stuff and people pay attention to you. But the reality is it's your lateroscosis or the lateral tracts in your anterior system that does your motor. All of that is degenerating. So you can feel everything because those are your posterior tracts. Remember how I said you were the anterior and you were the sensitive dorsal root ganglion? Well, your anterior from inside the spinal cord is getting destroyed. And so you're sensitive, but you can't do anything. And that's why you end up in a wheelchair and breathing, and that's why you have to have all the apparatus. Okay? There's no cure. You guys aren't in the business of diagnosing. which is really good. You're in the business of describing symptoms and signs. Nothing is worse than giving your patients this diagnosis. So if you go on into your medical career, and let's just say 20 years from now, you know, it's very tough to give people these diagnoses. I hate giving those diagnoses. It's absolutely brutal. So this, cancer, polyovarian cystic disease, I've had some horrible diagnoses I've had to give people. Besides the, like, sorry, we tried everything we could. There's other types where you're just having a really hard time. So I say give it to the specialist to diagnose, because sometimes we're finding different levels and different therapies are helping. Okay, multiple sclerosis, autoimmune disorder that attacks your myelin sheath. Yes.
I'm sorry, you still didn't say who had the Lou Gehrig's disease. Is it
Stephen
Superman?
Hawkins.
Steve
The one
Hawkins.
who had the Superman?
No,
No, Stephen Hawkins, the dude in the wheelchair.
Okay, okay.
He's fake.
Christopher Reeve had a horse accident and he cracked his neck.
Christopher Reeve, the old Superman, had a C1 burst fracture, right? And because it's above what's C level 2, right? C1, C2, it was above the diaphragm, right? He was riding a horse and he fell and he had a hyperextension injury, right? It was C1, C2 was fractured. Because your diaphragm is above what? C3, 4, 5, it was above that. There's no signal going down. And that's why he was unable to breathe on his own. It was a totally different, same effect, essentially, different mechanism. One was a disease, one was through trauma. Lumbar, another autoimmune, peripheral nervous system. Okay? Pins and needles, because it's what? Peripheral, it's not central. So they won't show any of that cogwheel rigidity in that. They'll show weakness, pins and needles at first, and then total weakness, but it will be on one nerve level or maybe a few, but it won't be gross and systemic, and it won't be bilateral. Myasthenia gravis, everybody know this one? Autoimmune disorder of what? The acetylcholine receptors at the end of that junction, right? So toward the end of the day, they get fatigued, but during the morning, they're actually pretty good because they slept all night and regenerated. So that's one of the defining characteristics. Huntington's disease. Not my specialty, right? Really bad. They go in under apoptosis early. So it's essentially like taking a 20-year-old and they start degenerating their brain tissue like an 80 and 90-year-old. And they're degenerating at such a speed that their brain is aging, even though physically they may be in their prime. They're getting dementia and things like that because their brain is apoptosis, the death of the cells is happening quicker than what is naturally supposed to occur. Okay. Neurological disorders. How do you even treat them? Don't say stroke. Okay. AFU, ABCs, good oxygenation. Make sure you're going to have. Sometimes when you have these diseases, you feel like you're trapped by them. So a lot of people with Parkinson's who need care, if there's no contraindication to them walking, you like to give them as much control as possible. They're gonna have special devices with them, right? Sometimes it's a computer where they can type and read and look at eye motions. Like, allow them to bring their devices with them, okay? Allow their spouse or their caretaker to bring special, like, they're almost trapped by the disease. You're not the first one to diagnose them for the disease, so give them a little bit of dignity, give them a little bit of power. Hey, do you want your head up, or would you like to be lying down? Give me a nod when we're good. Try to give them that type of dignity. It goes a long way. They're having a tough enough life, right? So you do the best you can within reason. You know what I mean? Okay. ABCs, do that one, establish your cardiac rhythm. We're always checking glucose, we're always checking opiates, we're making sure everything is going well. Oh, spinal cord disorders. One of my specialties, I love them. Spinal cord houses your peripheral nervous system, but it also houses your central nervous system. Spina bifida occulta or spina bifida just in general, that's when the back of the spinal cord, your vertebral bodies, the lamina and the spinous process don't form, they don't connect. So you can have an outpouching of your spinal cord, okay? Usually most common with neurotube defects of B vitamin deficiency, so you have to make sure. Most, 50% of patients with it, you'll see young kids that have it, you'll see a hairy, tough patch on the back. And you'll say, oh, that might be spinal bifida. And you can have a whole cyst or blastocele out with the spinal cord, you can press on it and like they'll have pain down their legs. Don't do that. Don't press on it. Does this hurt here? Does this hurt? Like, awesome, let's do this together. This is a cool magic trick. We don't do that. You just want to make sure. If you see a blastocele on their back, what position are we not transporting them in?
Super.
Okay, great. We might have them sideline. Okay, we're not trying to push it back in. We're not trying to do any of that. Okay. Hydrocephaly. You guys know what this is? Not
It's how it's
exactly.
described, but
Hydrocephaly means excess cerebral spinal fluid. Too much. And too much is pressing on the brain, right? But it's also in the ventricle, so it's also expanding in the brain, getting pushed out, and outside the brain, it's getting pushed out. Okay? So, there are cells that make CSF, your choroid plexus and your third ventricle, and also your lateral ventricles, right? So, you're making coffee because you need to make coffee. That's what you do. Okay? You make 6 every minute. Okay? You're just a barista going crazy. Okay? So he can either make 1 cup an hour, and then you can drink 1 cup an hour. Okay? What happens? He makes 6, and you can only drink 1 hour. You can only absorb through your sinus. You're being a sinus, you can only absorb 1. What builds up? Coffee. And so we can have 2 problems. We can have an overproduction where you're just a madman, or decreased absorption. A lot of the times you'll see it in kids where they don't have the absorption quality, right? So they put a shunt. They'll take it and they'll go into the abdomen because the abdomen can filter. You'll see it go all the way down. Okay? And so that is common. Okay? So we have either too much production, too little reabsorption, and that's normally how we go about it. Okay. Spinal cord compression. Okay. All right. I'm going to kind of explain this one the way you can look at the videos afterwards. I want to explain it how it is in real world, right? Because your spinal cord does through the lateral horns, you're sympathetic. Your sympathetic is what? From T1 down to L2. Okay? That's your sympathetic. Fight or flight, getting that tone, everything. When you get an injury, right, above that, you have no sympathetic tone from that area below. Do your arteries have muscles on them? Tunica media. So when you lose sympathetic tone, what happens to your arteries? They vaso. And what happens to your blood pressure? It goes down. So you're going to use norepi to bring them up, okay, if you need to, okay? But that's why spinal cord injuries from the level down, you end up getting hypoperfusion because all your arteries open up and that there's just no pressure. Does that make sense? Okay? And so a lot of times we don't understand. So anytime you have a spinal cord injury, right, especially from here all the way down, right, this is a huge area. If I get a spinal cord injury after L2, meaning someone got in a car accident, they complain of low back pain, there's no sympathetic chain there, right? Because your cauda equina stops at L2. I know it's not going to be a pressure issue, just in general. I'm going to still prepare for it. But I know if I got a mid-thoracic compression fracture, little old ladies, it's like, I fell and took a step and now I have severe mid-back pain. Oh, I'm getting ready for her to go, hypotensive. Not because she had internal bleeding, but because all her arteries are going to open up from there down. If it opens up from here down, we can put some extra fluid and we're going to do norepi. Does that make sense? And it's going to be bilateral, right? It's not going to be unilateral because that total spinal cord is going to get snapped in the center. Okay? So another way you can also do a epi drip, or you can do norepi, right? Those are the ones. Questions on that? It's a real important one. So anytime I get into like a car accident situation, and you guys know what Sperling test is, where you feel the spinous process on the back of your patient, you go and you can either tap or they feel a significant amount of pain or you feel some crunchiness, right? You're like, oh, I got some crunchiness. We need to be on board and we need to be ready for this. Okay? Not saying it's going to happen, but you better be ready because you'll get shocked. Once that inflammation starts, it'll start going pretty bad. Okay? I had that lady who got rear-ended by a Mack truck up in Kingston, and she had Harrington rods. She snapped 2 rods, okay, because she got hit so hard. And so she was going hypotensive. Put her on Norepinephrine, and then I called up to Albany because that's where she got the surgery. I actually put 10 milligrams of dexamethasone in her on doctor's orders to reduce the inflammation on the way up, okay? And that saved her from losing all that because she almost transected her cord. It was the inflammation that almost transected, not the act. But you guys will be better than me, so you guys will be okay. Okay? All right. Central pain disorder. Super tough to treat. Bell's palsy, muscular dystrophy, dystonia. What are you guys all going to treat this like?
Stroke.
Stroke. That's it. Not everyone else. Muscular dystrophy is going to be progressive weakness everywhere. I can't delineate from that from a tumor, neoplasm, or stroke. If they have a history, they're going to tell you their history. Then you can sit there and go over it. Okay? Any muddy points? Anything you guys want to go over? I know you're all tired. I can tell. Okay. ER, going to the crowd. Are they getting access to the PowerPoint?
They are.
Okay. Application. All right. Elderly man, skilled nursing facility, unresponsive by staff nurse. Okay, such patient, respirations are slow, shallow. Heart rate is low, weak, irregular. Skin is cool and clammy. You should. What do you guys think?
No, this is cool. We have to do ABCs.
We're gonna do what? We're gonna do what? Give me EKG while he's dying?
No.
No. Well, his respirations are slow and shallow. Heart rate is slow, weak and irregular, cool and clammy. Okay. Assist ventilation. Get him breathing. Get him breathing deep enough and see if that fixes the problem so he comes awake. Right? He could have extra CO2, he could be acidotic. You're just giving oxygen to secure the airway. Do your A and then do your B. Okay? While you do that, then you can do the BGL and the vitals afterwards. 66-year-old man, history, 2 prior strokes. What might he have now? Another stroke. You don't just have like a limit. I've had my 3 strokes in my lifetime. I'm done. I don't have. You can have a lot. Okay. Severe headache and then passed out. Respiratory efforts poor. Blood pressure is elevated. Pulse is slow and bounding. Glucometer reads error. I like it when it reads high. You should. What do you guys think? Oh man, they are starting transcutaneous pain. They're just going at it, huh? Just going at it. First of all, retake your blood glucose. If you ever get an error or just like high, doctors like to know it's high twice. Assist ventilation, apply cardiac pressure, start EV line, administer, right? T50W, access for level of consciousness. Okay. So, error or just when it says low. Sometimes you'll get an error and it says just high. Are we going to add more glucose if it says high? No. So, make sure. There's a guy called Tiny. His blood sugar was always high. I don't know why. He'd come to the ambulance unable to see, eating an ice cream sandwich. So we'd have to give him 2 liters. Tiny was a big boy. Okay. After you give him 2 liters, he's diluted enough that his sugar actually came down to a nice readable 520.
Nice readable 520.
Yeah. It was awesome. And he would always come out with an ice cream sandwich. Like, I don't know where he produced them from. It was awesome. Oh, look, he was sweet. He was a sweet guy. You just didn't realize that you took your insulin every day, not only when you feel like it. He was so nice, though. He's the cutest dog. All right, known heroin abuser. We have none of those in Poughkeepsie. Okay, 30-year-old man, unconscious, unresponsive, hypoventilating, bradycardic, hypertensive, 10 milligrams. Oh, the fire department. No effect. 30 minutes. Jesus, your lobby is booked up. Okay. Well, if 10 milligrams of Narcan didn't work, what? Everybody repeat after me. Narcan harder. No. Okay. Administer 25 grams of D50 without any measurements. Just throw it on them. Okay. Oh, your partner is intubated. He's an EMT. You guys are the ALS.
Double medic? Well, it
Oh,
could be
yeah,
double
I mean,
medic.
all right.
Not at Everest, but somewhere.
I feel like I'll get vitals before he like just okay.
I feel like I just want to
Yeah, ventilate.
Hyperventilate.
Ventilate. Just check me as you.
It's the hyperventilate.
Yeah, it's a hyperventilate, but like first of all, if you're gonna see this, make sure you get a blood sugar, make sure that you get the rest of your vitals, then check your BGL and prepare to intubate your partner. And make sure your partner is ALS.
Everyone's got to learn sometime.
Yeah.
Yeah, just not while I'm working.
And he's only preparing to innovate.
He's only
He's actually
preparing.
innovating.
How many
Maybe he's getting
partners-
the
all right.
equipment ready for me.
How many partners would you trust to prepare to innovate and trust them not to innovate? Let me just give it a shot. Come on, we're okay. No one's looking. He's a heroin user. Like, we're at the chicken shack. Let me do this. No, just because you're outside Kennedy Fried Chicken. We're not doing this, okay?
Just go get the Kennedy Fried Chicken.
Yeah. 59-year-old presents acute onset confusion. Left segment hemiparesis, meaning paralysis of the left side. Right-sided facial droop. Okay, cross crawl. Got left side, right side facial. Okay. Airways pain, breathing adequate. 150 over 100, pulse of 70, EKG. AFib. What's the number one cause of stroke? AFib. Okay. Taking picture medical history from my husband. The most important question to ask. When did you notice your wife's symptoms? That would be good. That would be good. Don't ask C. Don't ask C. You just piss people off. Oh, the last time she saw her doctor. Don't worry about her face right now. Don't do it. Time it. Make sure you write it down. Make sure you found out who witnessed it. Husband witnessed this 15 minutes ago. Okay? You want to make sure you find who the witness was. Okay? Dispatch for a middle-aged woman with a generalized. Okay, if you everyone here know where the pause is?
Mm-hmm.
What?
Pods.
Pause, the
In
homeless.
Poughkeepsie, the homeless one.
Okay. If one of them says to you, "Hey man, I found this out 10 minutes ago," what do you?
Hudson Valley Inn.
What do you? Now I'm gonna say, okay, bystander at the pods said they saw this 10 minutes ago. That's how I'm gonna note it. Okay. Because I want to know who the bystander is that saw it. Because 10 minutes ago could have been before they took some heroin with them, and then it's actually been an hour and a half. I want to make sure. Best middle-aged woman, generalized weakness, 18 hours duration. Oh, mother. Your primary side, right-sided hemiparesis, left-sided facial droop, bilateral equal reactive pupils. VGL 70, good or bad? Not bad, not too bad. Could be worse. Could be. But in 70s, Jane dying in 70. Increased movement. En route to the hospital, you know, increased movement right arm. O2, nasal cannula. IV in place. Okay, increased movement. Middle-aged woman. Right-sided hemiparesis. Her right side is starting to feel better. What do you guys think? Okay, you're thinking that. What are we treating for? That's right. That's right. You want to make sure you do all the things. How do I treat it? Just like a stroke. That's it. Okay. 7-year-old experienced seizure. Dinner table, stop speaking, stands blinking her eyes. Okay? Less than a minute, condition rapidly improved. What do you guys call this one? Absent. Absent. Okay. I have these about 2 to 3 times a day. Okay. Okay. I'm gonna tell you when I have them. Come home. Wife asks me about my day. Sit down with my kids. And if I didn't do something right, what do I have? I have
Absentee.
an absentee to put that one in. Okay, it's controlled.
Smart.
It's controlled. Okay, and my wife always knows when it happens because I put my left ear to her, the ear that can't hear. So I take the abuse on the ear I can't hear, and then she's like, "Are you listening?" And I'm like, "Are you making fun of someone with a disability?" And I'm like, it's an easy way to get out of an argument. And she's like, "That's really messed up." I'm not saying to do that. But if you have a disability, okay, so just use it as much as possible. Okay. There you go. 18 Sun, EMS station. Season. They're there for 10 minutes. Seizures. Takes Depakote. Cyanotic, breathing erratically, generalized muscle twisting. Okay. If they're blue, what are we doing? There you go. There we go. And check the blood sugar at the same time. Okay. They may be lacking blood sugar because they have seizures. Okay. Always do a full exam. BSI, keep yourself safe. ABCs, ABCs. Run down your list. Get used to ABCs, ABCs, intervention, ABCs, intervention, ABCs. I can't stress it enough. If you get your system down, when you guys get to patients, the least amount of brain power is going to be needed to maintain your system so that you can use your brain power to think about treatment and options, okay? Just how you do it. Homework.
No.
I didn't write this. Okay, I didn't write this. This is very good. Okay, I hope this helped. I hope this was better than just reading out of your textbook. Any questions? Anything you want to bring up? Your biggest thing is to treat everything like a stroke and just be proactive. Okay, I've had a lot of them where I knew it wasn't a stroke, but I didn't know exactly what it was, and it turned out to be something totally different than what I thought. But because I got them there, it saved them from a lot of problems in the long run. And so your job is not to make definitive answers. Your job then is to get definitive help. That's it. Congratulations, you guys got this far. See you guys in December.
Interesting.
Yay.
Yeah.